Good evening, everyone. I'm Gaini Ratnasinghe, President of Paediatric Nurses Association. It's a very pleasure to address you all through the virtual platform. We warmly welcome all the participants to the first online session of the webinar series organized by the Paediatric Nurses Association in collaboration with Sri Lanka College of Paediatricians. This is our first step to gather you all through virtual platform to update knowledge of nurses who are working in pediatric setting. Today theme is constipation in children and nursing aspect of pediatric constipation. Today our guest speakers are Professor Shaman Rajindrajith and Nursing Officer R.L. Chandralekha. Over to you, Professor, to enlighten us on today's topic. Thank you.
Collaborative work between Association of Pediatric Nurses as well as Sri Lanka College of Pediatricians. I'm greatly honored by having this opportunity to do the first lecture with our colleague Chandralekha. So I will start the basic knowledge about, I will share with you the basic knowledge of constipation, and Chandralekha will continue with the other aspects of nursing aspects of constipation. So my task is very simple. I'll tell you what is happening. So I would always like to take it from a clinical point of view. So we describe a patient whom I have seen in the recent past. So we have a 4-year-old boy presented with history of reduced bowel frequency and hard stools for 6 months duration. The mother also says that the child refuses to pass a stool in the potty and stiff his body when there is desire to pass the stools. On examination, the clinician found a well-grown child. The abdominal examination reveals a large fecal mass in the lower abdomen. The rest of the system examination is unremarkable. I'm sure, my friends, you all have seen somebody like this in your nursing career, right? So the next question is, we will define constipation using this child. So what is childhood constipation? Now, if I want to put this in Sinhalese, right? Hamoma ahala තියෙනවා අලියා සහ අන්ධයන් තුන්දෙනාගේ කතාව. Right? Now මෙතන ඉන්න කට්ටිය බැලුවොත් දැන් මේ දුඹුරු පාට ඇඳ බැඳන් ඉන්න මහත්තයාට පේන්නේ අලියා බටයක් වගේ. නිල් පාට සූට් එක අඳන් ඉන්න මහත්තයාට අලියා පේනවා කඹයක් වගේ. Right? අනිත් මහත්තයාට අලියා පේන්නේ මොකක් වගේද? බිත්තියක් වගේ. So දැන් මේ constipation වල management එකේදී තියෙන ලොකුම ප්‍රශ්න constipation හඳුනා ගැනීම. මොකද definition. It's like this. If you hold on to one clinical symptoms, you are not going to get that. එක රෝග ලක්ෂණයක් පමණක් අල්ලගත්තොත් ඔයාලට මේක පේන්නේ නැහැ. ඔයාලට පේන්නේ රෝගයේ කැලලක් පමණයි. අලියා සම්පූර්ණයෙන් පේන්නේද නැත. Constipation පේන්නේද නැත. Therefore, I would urge you all to understand constipation from more than one clinical symptoms. To make it, there is a group called Rome group. Rome group define constipation and all the other functional GI disorders every 10 years. So the last iteration was at 2016. In that, they have defined constipation like this: must have 2 or more of the following criteria. So defecation frequency less than 2 times, fecal incontinence, retentive posturing. Some children, when they want to pass stools, they just hold on to it by stiffening their body, as I described in the history. So if they have that, if they have painful or hard bowel motion, if they have large diameter stools, and if they have fecal mass in the rectum on examination. If we have all that, 6 criteria, out of that, if you have 2, you have constipation, not 1. That is what I want to express. So that is number 1. So epidemiology of childhood constipation. What is happening around the world? How many children do have constipation across the country, across the world? So this is the world map. You can see our data represents Sri Lanka. So in the global sense, about 9.5% of all children in this world do have constipation. Right? It's a huge number, right? It's a huge number. So in addition, if you look at what is happening with regards to numbers, with regards to prevalence outside Asia, ආසියාවෙන් පිට තියෙන රටවල් වල prevalence ගත්තොත්, you can see very high prevalence in Brazil, right? With 2 studies, very high prevalence in Nigeria, right? And there is this is what is happening outside Asia. Now look at what is happening inside Asia, right? You can see very high prevalence in Hong Kong and Taiwan, and even in our country. This is our own data. So how large number of children are suffering from constipation. So now those days, good old days, what people tend to tell us, constipation is a disease of the Western world. Now look at the data from Asia, right? It's alarming. So we believe, constipation prevalence එක දැන් තියෙන්නේ ආසියාවට වැඩිය. යුරෝපයට වැඩිය ආසියාවට. So that is why I'm asking whether epidemiologic epicenter is moving from west to east. Right? So any constipation happening, what is the etiology of childhood constipation? So one thing, important thing that you need to remember is constipation is not due to various organic disorders. Right? The main problem is functional constipation. They have functional, their gut is not working appropriately. That is why they develop functional constipation. I will explain it to you very quickly in the next slide. Now imagine this is the rectum. This is a fecal mass which coming very easily in a normal child. When the mass get enlarged and when the desire to pass the stools urges get more, then they pass the stools. Now there are some children like this, right? When they are supposed to pass a stool, they don't pass the stools, they withhold the stools, right? When they withhold the stools, they become rectal, there's a large rectal mass which formed by feces. So the water get absorbed through this rectal mucosa and this become very hard. Make a visala large fecal mass which is difficult to pass. Then make a yanna giyahama me ළමයට රීදෙනවා because this is large and hard. එතකොට ඒ ළමයි කරන්නේ තවදුරටත් මල පහ කරන එක නවත්තනවා. So they stop passing stools. So this is the origin of constipation in young children. So for some funny reason they stop passing stools. Then what happens is then the stool passage of stools becoming painful. So they withhold stools. එතකොට ඉතින් මේ stools amount එක ගොඩක් එකතු වෙවි මේක ඉස්සරහට යනවා. මේක තමයි childhood constipation එකේ මූලිකම ප්‍රශ්නේ. What are the risk factors? අපි බලමු risk factors මොනවද කියලා. Now this is our data again. So අපි බලමු males have a higher tendency to develop constipation than females. Younger the age, higher the prevalence. So young males will develop constipation more than others. Right? Number 1. Number 2, low fiber diet. Diet low in fiber is a major risk factor for constipation. There are enough studies across the world that has shown that. The normal normal fiber amount එක මිනිස්සෙක් කන්න ඕන 18 years අවුරුදු දෙකක ළමෙන් නම් 2.5 ග්‍රෑම් 7යි දවසට. So ඒ වගේ හදා ගන්න පුළුවන්. roughly එතකොට ඒ වගේ ප්‍රමාණයක් කන්න ඕන. So this is what it is. So junk food. When you eat too much of junk food, you develop constipation. There's this study from Hong Kong, very beautiful study. They show very clearly junk food lead to constipation. Then psychological factors. The අපි ගණන් ගන්න ඇති දේවල්. Scholar psychological factors like separation from the best friend, failure in an exam, severe illness among family members, right? Illness among family members, parental job loss, frequent punishment at home. All these lead to severe constipation in children. Right? Again, child abuse, physical, emotional, and sexual abuse in children will lead to constipation in children. Right? And then, ඊළඟට අපි බලන්න ඕනේ මේ ළමයෙක්ව බලාගන්න කොහොමද කියලා. කොහොමද ළමයෙක් constipation කියලා වහම how are we going to evaluate? Right? So let's see what we can do as a clinician, anybody. So they present with various symptoms like reduced frequency of stools, pain while passing stools, fecal incontinence, stool withholding, occasionally passing large voluminous stools, straining, bleeding PR, abdominal pain, urinary incontinence. All these are presenting features. So when they come, we take a good history, elaborating symptoms of constipation, bowel habits, their bowel habits, right? And blood in stools, and there's a family history, there is dietary habits, as I said, and past medical and surgical problems, which Chandralekha will discuss later, and psychological history, as I said, psychological stress lead to constipation, social history, may take on. After that, you can take a good examination, right? Growth parameters, dysmorphic features like children with Downs and all that, they are more prone to develop constipation. Then a good abdominal examination and perianal and rectal examination and lower limb neurological examination. So these are essential parts of examination. Now, when you see these things, they indicate serious problems, which are not organic, which are diseases, right? Now, if you have somebody with delayed passage of meconium and bilious vomiting, that indicates intestinal obstruction, right? If you have failure to thrive, indicates severe organic disorders leading to constipation. And if you have developmental delay, that indicates neurologically malfunctioning gut, right? And if you have ribbon-like stools, that indicate Hirschsprung disease. If they have asymmetric growth in the lower limb, that indicates abnormal lower limb neurology. So neurological causes for constipation. So that if you see one of these things, it is a trouble. So you have to know that, right? How should diagnosis be made? Make lecture ke ඔක්කොම ඒවා ඔයගොල්ලන්ට අමතක කරගන්න මෙන්න මේ වාක්‍ය විතර මතක තියාගන්න. Constipation is a clinical diagnosis. You don't need any investigation. You can just find out 2 criteria from that 6 Rome criteria, which should be fulfilled for a month, and then you can diagnose constipation with it, right? So investigations have no place in the management. You know, people do a lot of things like x-rays, thyroid functions, cow's milk allergy. This is not going to help you at all in diagnosing and managing constipation in children. Now, you see people do a lot of x-rays and see, and they tell the rectum is loaded with fecal mass and so on and so forth. But there is very little scientific meaning to this in day-to-day management of children with constipation. Similarly, thyroid function test, it's like everybody who gets constipation get a thyroid function test done, which is again not going to be very helpful to management of children. So colonic transit time, you can measure the transit time, the time that taken by stools to come from cecum to rectum. So it can be measured using radiopaque markers, radionuclear scintigraphy, and wireless motility capsules. All that can be done. Children with significant functional constipation have prolonged transit time, right? Malapaha cecum එකේ ඉඳලා rectum එකට එන වේගය ඉතාමත් අඩුයි සමහර constipation ළමයින්ගේ. So naturally they develop constipation, right? දැන් මේ තියෙන transit study එකක් අපි කරපු. So ඔයාලට පුළුවන් බලා ගන්න මේකේ දැන් මේ rectum area එකේ තමයි ඔක්කොම markers ටික එකතු වෙලා තියෙනවා. මේකේ බැලුවොත් අනිත් එකේ මේ හරියට ටිකක් තියෙනවා, මේ හරියට ටිකක් තියෙනවා. So colon එක මුළු colon එකම හරියට වැඩ කරන්නේ නැහැ. Something like that. දැන් මේ පරණ දේවල්. අලුතෙන් ඒවා මොනවද? High definition anorectal manometry. Manometry කරත හැකි anorectal manometry. When you do that, you can assess the sphincter function, rectal sensation, anorectal reflexes, all can be assessed. This is a very sophisticated machine which we are trying to buy for the Lady Hospital. We will have it very soon. So we can understand their rectal function and intestinal function. So high resolution colonic manometry, colon manometry පීඩනය මනිත හැකි මේ වගේ ගැජට් එකක් හයි කරගත්තාම රේඩියොලොජිස්ට් කෙනෙකුට කියලා මේක දාගන්න පුළුවන්. දාකට පස්සේ මේකේ තියෙන anomalies අපිට බලා ගන්න පුළුවන් කොහොමද යන්නේ කියන එක. Those things, if they are abnormal, motility is going to be abnormal, then you develop constipation. And කොහොමද manage කරන්න මේක? This is the management paradigm. There are several things that you can do, but you start with the least invasive one. So lifestyle modification. You can do behavior therapy. You can give laxatives. You can do rectal evacuation. You can do neuromodulation. I will explain it. And there are surgical interventions as well. So first thing, as nurses and as doctors, what we need to do is explain them. So prevalence of childhood constipation, you can say, right? Natural pathophysiology of the disease, you can draw the diagram and show that. Interpretation of investigation results, you can play that. And you can explain the management plan. This is what I'm going to do. And then the follow-up plan and long-term prognosis. Now, toilet training is one of the crucial things in management of children with constipation. Chandrelekha will speak about that later in her lecture. So fiber. Now you have to optimize fiber in the diet, but don't give it too much, because too much of fiber is not going to be very helpful. If you assess the diet, when you find out the child is not taking enough fiber, according to the plan that I give, age in years +5, so you can increase up and optimize it, but don't go and give too much of fiber, because that's not going to be very helpful. ඒ වගේම constipation තියෙන ළමයින්ට හරියට වතුර බොන්න කියනවා, වඩ වැලේ වතුර ඔක්කොම ටික absorb කරගෙන urine output එක වැඩි වෙනවා මිසක් කවදාවත් stool output එක වැඩි වෙන්නේ නැහැ, stool soft වෙන්නේ නැහැ. Probiotics. There are several probiotics that people use, but ඒකෙන් තාම evidence මදි මේක හරියට constipation වලට පාවිච්චි කරන්න පුළුවන් කියලා. right? දැන් අපි බලමු බඩ වැලේ කක්ක හිරවල තියෙනවා නේ වගේම රෙක්ටම් එකේ කක්ක හිරවල තියෙනවා නම් fecal disinfection කරන්නේ කොහොමද කියලා. හුඟක් අය පාවිච්චි කරන්නේ suppository එකක් හරි enema එකක් හරි, but I don't do that. I use generally polyethylene glycol, movicol කියලා තියෙනවා trade name එක. මේක අරගෙන 125 ml of water දිය කළා බොට දෙනවා දවසට එකපාරක් හරි දෙපාරක් depending on the situation. Most of the time fecal mass gets softened, and then children will be able to pass the stools without any major issue. Right? It is more effective. The rectal root එකෙන් දේවල් දානකොට පසපැත්ත රිදෙන්න ගන්නවා. There is a pain in the rectum. Therefore, children withhold the stools more and more. So you might aggravate the problem rather than sorting it out. Maintenance therapy, once the rectum is empty, you can use osmotic laxatives, stimulant laxatives like lactulose, polyethylene glycol here, and senna and bisacodyl here, and there are now new agents as well. You use one of these things and keep them going on the drugs at least for 2 months, and then try to slowly tail it off and take them off drugs and keep on toilet training and educating them on normal bowel habits. Laxative to maintenance base, as I said, polyethylene glycol, lactulose, Maxalf you still can use, and there are bisacodyls and senas you can use as a stimulant laxatives. What are the novel therapeutic innovations? Now, this is a new one. This came about 6-7 years ago. What they do here is මෙතන කරන්නේ මේ rectum එක innovate කරන sacral nerves තියෙනවා. ඒ nerves තමයි S3-4-5. S3-4-5 තැන් වලට electrode එකක් හයි කරලා මේක stimulate කරනවා. ඒතකොට මේක නිකම්ම contract වෙනවා. So there are research like this which is going on, and some of them say it is very good, some say it is not so good, but තාම ඒක ගැන හරිය නිවැරදි තීරණයක් නැහැ. Some people use it. Surgical interventions මොනවද කරන්න පුළුවන්? We can inject botulinum toxin to the anal sphincter. We can do antegrade continent enema, sigmoid resections, colorectal resection, subtotal colectomy, and proctocolectomy and ileal anastomosis. A lot of things that we can do. Now, this is antegrade continent enema. I mean, there are people, children in the Late Ritchie Hospital who had this. So what we do here is fix a tube into the cecum and send water through this thing, and then the fecal matter get evacuated. Right? This is a very good thing, but there are few complications that is important that is needed to be addressed. So the sigmoid resection, if the sigmoid is large and filled with fecal mass, how much laxative you give, this will not come out completely. So what you need to do is assess it and take this part off, and end-to-end anastomosis. So colostomy for a temporary time, and then you can redo the anastomosis. What is happening? What is going to happen to them? Right? Generally, they have a very good prognosis. They improve with their disease with treatment. Right? But some of these children go into adulthood with constipation. If they have older or age of onset, if they delay seeking medical advice, if they have low defecation frequency, they are prone to get into troubles as time goes. So to end my lecture, I would say constipation is a major public health problem. 9.5% of children get affected. It significantly affects lives of children and their families. Risk factors are highly prevalent, and routine investigation do not help in day-to-day clinical management. Multifaceted approach is the best way in managing these children. novel therapeutic options are available for children who are refractory to conventional management. Thank you very much for your patient listening.